Chapter 1: Contemporary Maternity Nursing. Maternal and newborn nursing encompasses a wide scope of practice typically associated with the childbearing. It includes care of the woman before pregnancy, care of the woman and her fetus during pregnancy, care of the woman after pregnancy, and care of the newborn, usually during the first 6 weeks after birth. The overall goal of maternal and newborn nursing is to promote and maintain optimal health for the woman and her family. Maternity nurses teach about pregnancy, the process of labor, birth and recovery, and parenting skills. They provide continuity of care throughout the childbearing cycle. Your book describes an excellent model for nurses who care for women and children, that is the International Confederation of Midwives. In your book on page 3, box 1-1, The Vision for Women and Their Health, the International Confederation of Midwives envisions a world where women are respected and treated as persons in their own right in all societies. Women stand as equal partners with men in the world. Women are recognized as crucial to the health of any nation. Women and their families are part of a healthcare system with high quality care and easy access when needed. Women have the right to choose from among safe options for care throughout their lives, including high-quality, state-of-the-art care from competent providers who truly care about the woman and her health. Women are educated and empowered to delight in a strong sense of self, to trust their bodies, to plan their pregnancies, and to make wise choices in their health care. Women experience a reasonable standard of living, including a clean and safe environment, healthy food, and a reasonable place to live. No woman has to fear for her life or the life of her baby when she is pregnant. Women believe that birth is normal and prefer to avoid unnecessary intervention. Healthy People 2010 is the United States Agenda for Improving Health. It has 2 goals. One is to increase the quality and years of healthy life and to eliminate health disparities. Focus Area 16 for Healthy People 2010 is located in box 1-3 on page 5 in your book. This has to do with maternal, infant, and child care. The goal is to improve the health and well-being of women, infants, children, and families. The United Nations Millennium Developmental Goals. They are 8 goals to be achieved by 2015 that responds to the world's main developmental challenges. The graph is located in box 1-4, page 5 of your textbook. The healthcare delivery system itself can create barriers. A major factor that affects access to care is health insurance. People without health insurance typically cannot afford to seek health care for maintenance and prevention interventions. The working poor may not earn enough money to afford the health insurance or medical care, and part-time workers do not always receive health insurance benefits. Financial barriers are one of the most important factors that limit care. Childbirth is the leading reason for hospitalization in the United States for both private insurers and Medicaid. Hospital maternity and newborn charges exceed those for any other condition. In the U.S., hospitals, vaginal and cesarean deliveries cost approximately $8,000 and $11,000 respectively. Other causes that influence the healthcare delivery system: transportation. Getting to and from appointments can be challenging for clients who do not drive or own a car or cannot use public transportation. It can be difficult for these clients to attend all recommended prenatal health care visits, especially if the woman has other small children who must be taken along on the visit. These challenges can reduce the adherence to scheduled appointments and follow-up visits. Language is also another barrier to health care. If a healthcare worker cannot speak the same language as the client or does not have a trained interpreter available, a barrier is created. Clinic hours must meet the needs of the clients, not the healthcare providers who work there. Evening or weekend hours might be needed to meet the schedules of working clients. Clinic personnel should evaluate the availability and accessibility of the service they offer. Unfortunately, some healthcare workers exhibit negative attitudes toward poor or culturally diverse families, and this could deter these clients from seeking health care. Long delays, hurried examinations, and rude comments by staff discourage clients from returning and receiving the proper health care. Care during pregnancy and childbirth. Women must be viewed holistically and in the context in which they live. Their physical, mental, and social factors must be considered because these interdependent components influence health and illness. Maternal mortality and morbidity is a measure of a nation's commitment to the status of women and their health. The leading causes of pregnancy-related deaths in the United States are hemorrhage, blood clots, hypertension, infection, stroke, amniotic fluid embolism, which we'll talk about later, and heart muscle disease. It is estimated that over half of these deaths could be prevented with better access to care, better quality care, and positive changes in the health and lifestyle habits of women. Prenatal care may promote better pregnancy outcomes by providing early risk assessment and promoting healthy behaviors such as better nutrition, and for moms who smoke, encouraging smoking cessation while they're pregnant. A shift in settings from acute care institutions to the home has been occurring. Even childbearing women at high risk are cared for in the home. Typically, women who are high risk and cared for at home, we have home monitoring services where the woman can actually hook herself up to the fetal monitor. We can monitor the baby. We can see if the mom is having contractions, and if she is, the nurse from the health agency will call the mom and usually will tell the mom it may be a good time to go to the hospital or call your physician to be seen. One problem that many women who are workers face is whether or not they are going to breastfeed or not. Most women either get a 6 or 8 week period off after the birth of their baby, and typically they have to go back to work. Many facilities are now setting up breastfeeding rooms for moms so that moms have time to go and pump throughout the day. I know at the facility I work at, we had a room in our newborn nursery set up where women who worked could go pump, and even moms who had babies in the nursery for an extended period of time, they could come in and actually pump while in the hospital, or even come in and breastfeed the baby in the hospital. Some of the international concerns that the book talks about: the female genital mutilation is the removal of part or all of the female external genitalia for cultural or non-therapeutic reasons. We had a group of women not long ago, probably about 4 to 5, maybe a little bit more than that, maybe around 2004, 2005. They were refugees that came from Africa, and many of the women were pregnant, and many of the women had the female genital mutilation. We had issues with our physicians. The physicians were trained on it, the nurses were trained on it, and a lot of the physicians were very hesitant to follow the wishes of these African women because they wanted to be sewn back up after they delivered their babies, and many of the doctors were really against it. But we had clergymen from the church who were they were the same ethnic background as these Africans. I think they were from, I really don't remember where they were from, but we had the clergymen come in and do a lot of informational sessions, because a lot of these women, if they weren't sewed back to how they originally were, they were shunned from their community. So a lot of the women, after they delivered their babies, they were requesting to uh, be sewn back up. It was a really different experience. I remember laboring a woman who had the female genital mutilation. Actually, I think I've labored maybe two or three. One or two were from Africa, and the other woman, she was, I want to say Middle Eastern. But it was a difficult thing because the vagina, they have it, it's the vagina's not stitched, but the labia minora and majora are stitched. So it was kind of hard trying to do a vaginal exam, and we tried with anesthesia to almost have them totally numb, but every time we would go to try and do a vaginal exam, it was very painful to them. So it was a different experience, and basically we just did a hands-off approach. And once the woman was saying that she needed to push, the doctor would do something similar to a episiotomy, where they would just open up so that the vagina could be exposed and that the baby could be delivered. The infant mortality rate is the number of deaths occurring in the first 12 months of life. It is also documented as the number of deaths of infants younger than 1 year of age per 1,000 live births. Despite the rapid decline in infant mortality for industrialized countries during the 20th century, the United States infant mortality rate has declined only marginally. Racial and ethnic disparities in infant mortality have persisted and increased, as have the percentages of preterm and low birth weight infants. Infant mortality is a complex and multifactorial problem that has proved resistant to intervention efforts. The infant mortality rate varies greatly from state to state as well as among ethnic groups. The United States has one of the highest gross national products in the world and is known for its technological capability. The United States continues to lag behind in preserving infant lives when compared to other industrialized countries. The main causes of early infant death in this country include problems occurring at birth or shortly thereafter. These include prematurity, low birth weight, congenital anomalies, sudden infant death syndrome, and respiratory distress syndrome. This really, it highlights the film that we saw in class today, Babyland, the infant mortality in Memphis, Tennessee. And it really shows you that although we are one of the most industrialized nations, we still have problems with our infant mortality rates. So we really need to intervene and do something to help our babies. Evidence-based nursing practice involves the use of research to establish a plan of care and to implement that care. Evidence-based practice is a problem-solving approach to making nursing clinical decisions. It involves the collection, interpretation, and integration of validated research-derived evidence from a variety of resources. This model of nursing practice includes the use of the best current evidence in making decisions about care. Widespread use of evidence-based practice may lead to a decrease in variation of care, while at the same time increasing the quality of care. Nursing standards of practice in perinatal nursing have been described by several organizations, including the ANA, or the American Nurses Association, which publishes standards for maternal child health nursing; AWAN, which publishes standards of practice and education for perinatal nurses; the American College of Nurse Midwives, which publishes standards of practice for midwives; and the National Association of Neonatal Nurses, which publishes standards of practice for neonatal nurses. Also, you may have heard of ACOG, which is the American Association of Obstetricians and Gynecologists, and they provide standards of care that our doctors must follow that are in the arena of maternal child health care. Law and ethics are interrelated and affect all of nursing. Professional nurses must understand their scope of practice, standards of care, institutional or agency policies, and state laws. All nurses are responsible for knowing current information regarding ethics and laws related to their practice. Several areas are of particular importance to the healthcare of women and their families. These include abortion, substance abuse, intrauterine therapy, maternal fetal conflict, stem cell research, umbilical cord banking, informed consent, and confidentiality. In maternity, the ethical principles of beneficence and autonomy provide the fundamental framework that guides the management of all pregnant women. Because the fetus also needs to be considered, autonomy can become a complex issue, giving rise to what is sometimes called maternal fetal conflict. And maternal fetal conflict can lead to many of the problems that we see today, such as stem cell research, intrauterine fetal surgery. Intrauterine fetal surgery is kind of new, but it's been going on for years. But basically, if a baby has some type of genetic anomaly, a surgeon can go in and correct the problem while the baby is still in utero. There are definitely some pros and cons. The pros is if it's successful, the baby can be born and not have any issues. The cons, whenever you do surgery, the risk of infection, the risk of preterm labor, the risk of hemorrhage, the risk of injuring the fetus are also, they have to be weighed. So we kind of weigh the risk versus the benefit. Surgery for infertility, we'll talk about that a little bit when we talk about infertility. Surrogate childbearing. Women who cannot carry a pregnancy in their uterus, they have surrogates who will carry the baby. So the issue of that we've seen in the news is pain for this surrogate mom. We've had surrogate moms who, after the pregnancy was over, not want to give the child to the genetic parents. So there is a lot of things that can cause ethical issues in the maternity arena. So here's a question. To assess a mother's risk of having a low birth weight infant, the most important factor for the nurse to consider is A, African American race, B, cigarette smoking, C, poor nutritional status, D, limited maternal education. The answer is A. Being African American is the highest or the number one important factor for the nurse to consider when assessing a mom's risk for low birth weight. Socioeconomic status, education, all of those things don't come into play. The mom's race alone, being African American, puts the mom at significant risk of having a low birth weight baby. A lot of people think it's the environment, it's the nutrition or the diet. We really don't know. One of my own personal theory is that a lot of African Americans suffer from hypertension. And typically a lot of my moms who are pre-eclamptic or become eclamptic, and this is just in my own practice, I would say 90% of them were African American. So it could be genetics, it could be environment. We really don't know, but we are doing a lot of research to figure out and try to change this. Okay, key points to remember from Chapter 1. Maternity nursing focuses on women and their infants and families during the childbearing cycle. Nurses play an active role in shaping healthcare systems to be responsive to needs of contemporary women. Childbirth practices have changed to become focused on family when alternatives for care. The United States ranks 26 and Canada ranks 16 among industrialized nations in infant mortality rates. Integrative medicine combines modern technology with ancient healing practices and encompasses whole of body, mind, and spirit. Perinatal practice is increasingly evidence-based. Healthy People 2010 provides goals for maternal, infant, and child health, and ethical concerns have multiplied with increasing use of technology and scientific advances. This concludes the audio lecture for Chapter 1. Thank you.